Hello everybody, welcome to number 1 Doctor channel. Today we will talk about lymphedema. Lymphedema results from the obstruction of lymphatic flow, owing to inherited abnormalities of the lymphatics, their obliteration by disease, or their operative removal. It is characterized by an excessive accumulation of interstitial fluid. Affected individuals are prone to infections cellulitis in the affected areas toes, though with lymphangitis. The causes of lymphedema may be divided into congenital and acquired. Inherited lymphedema. There are two autosomal dominant inherited forms of lymphedema, also referred to as primary lymphoedemas. Both are more common in women. Type 1, also known as Milroy's disease, non-Milroy disease, and primary congenital lymphedema, is very uncommon, and is often associated with a mutation in the FLT4 gene, which encodes vascular endothelial growth factor receptor 3, VEGFR3. It is characterized by onset soon after birth with lower limb swelling. Type 2, also known as Mejia's syndrome 7, is associated with mutations in FOXC2, a forkhead family transcription factor gene. It is characterized by lymphedema that is particularly severe below the waist. It has been arbitrarily divided into lymphedema precox, which develops between puberty and the age of 35, and the less common lymphedema tarda, which develops in adult life. There are 3 principal pathological processes affecting the lymphatic channels in congenital lymphedema: aplasia, hypoplasia, and varicose dilation. Metalymphatics. Acquired lymphedema. Post-inflammatory, the result of fibrosis obliterating the lymphatics following repeated attacks of streptococcal cellulitis, particularly when the lymphatic drainage is already compromised. Filariasis, a chronic inflammatory reaction is set up with consequent lymphatic obstruction. There is gross lymphedema, especially of the lower limbs and genitalia, often called elephantiasis, following radical surgery, particularly after block dissection of the axilla, groin or neck. Post-irradiation fibrosis, malignant disease, late edema of the arm after axillary clearance, and radical mastectomy is often indicative of massive recurrence of tumor in the axilla occluding the residual lymphatic pathways. Special investigations. Lymphocentigraphy involves injecting a radiolabeled protein subcutaneously and monitoring its movement through the lymphatics. It will confirm lymphatic obstruction. Magnetic resonance imaging may be used to confirm the cause of obstruction in secondary cases. Differential diagnosis. The diagnosis of lymphedema depends first of all on the exclusion of other causes of edema, for instance venous obstruction, cardiac failure, or renal disease, and, second, on demonstration of one of. It was previously taught that lymphedema could readily be differentiated from other forms of edema on the simple physical sign of absence of pitting in the lymphedematous limb. However, lymphedema of acute onset will initially pit on pressure, although it is true that, when it becomes chronic, the subcutaneous tissues become educated from fibrous tissue replacement, and pitting will not then occur. Treatment of congenital lymphedema. Conservative, mild cases will respond to elevation and graduated elastic compression stockings. Surgery. In severe cases, surgery may be appropriate. 2 approaches are possible. The first is to remove all the edematous subcutaneous tissue down to the deep fossa with removal of the overlying skin as a split skin graft, and its reapplication directly to the deep fossa. This leaves considerable scarring. The second approach is to provide alternative lymphatic drainage by passing obstructions, such as by tunneling the tongue of omentum down to the inguinal nodes, to provide drainage along mesenteric lymphatics to the thoracic duct, by passing obstructed iliac nodes. Thanks for watching our video, and hope to see you again in more next videos. With my best wishes, Dr. Atif Ahmed.